Good afternoon. We're going to spend a few minutes just talking about, and we're going to use this as a precursor before we jump into the text that we're going to use for this health economics class. We've already provided a couple, or I've already provided a couple of videos talking about Arrow's, the seminal article that, required reading when I was in graduate school, because it focuses on the economics of medical care. And it, again, a lot of academics feel like it was the article that kind of jump-started the transfer of payments and the redistribution of disposable income, and got the ball rolling for the establishment of Medicare and Medicaid and Champus and TRICARE. So we've kind of gotten that kind of under our belt, and it's, it was looking at, the late 50s, early 60s. And now we're going to just spend a few minutes kind of bringing things up to date, just at least to some extent. And it's as I always tell classes, that when I'm providing information, my goal is always twofold. It's one, I want to help you build a toolbox that you can use either to enhance your academic career or to enhance your career and improve the probability of, when you get into the workforce, that you're going to be a valuable asset to that company that you go to work for. So just remember, it's to advance your academic career, or it's to help you succeed in life as you move forward into the workforce. So don't ever hesitate to reach out and ask me questions, or tell me that I'm completely out in left field about something, or that was the goofiest talk that they'd ever heard. And if they were providing a lecture on a given topic, here's the way they would do it. So anyway, anytime you need to reach out to me, don't hesitate. It's actually enjoyable, the interaction with students. It's a little difficult when you're doing these asynchronous classes, but again, I'm here to help and to be of value to you as you pursue an academic career, or as you ready yourself to go out into the marketplace. But we're going to start this first one out, and we're going to talk about the financial coin. And if you think about healthcare, it all boils down to, there is a financial coin involved. And on one side of that financial coin, actually, let's back up. When we are talking about, go back to your microeconomics classes. And if you think about the microeconomics classes, and when you're talking about micro, it's economics is a social science. And it's a study of choice. It's based on, what differentiates it from other social sciences as its building blocks or opportunity cost, self-interest. And when I say self-interest, it means that individuals, consumers, entities, companies that, organizations you might work for, governments, whomever, it's based on self-interest, and they're trying to optimize something. If you're, you may be trying to, if you're an individual, you may be trying to maximize the utility you receive from your disposable income. You're trying to minimize the cost of rent and transportation and food and your necessities that for you and your family. So everybody in their self-interest is trying to optimize something somewhere along the way. If it's a entity, you're trying to maximize profits. I mean, organizations are in business to maximize profits and generate profits. So, and then lastly, decisions are made at the margin. So just kind of keep those three things in mind, because that's going to help you understand the concept of this financial coin. So think about the financial coin like any other coin. The financial healthcare coin, it's got two sides. On one side, you've got your provider sitting there. The providers want to maximize the profit that they are and the revenue that they receive from providing healthcare goods and services to a consuming population. They're trying to maximize the dollars coming in. They're trying to minimize the expenditures so that it's generating higher profit. On the other side of that coin, you've got the payers. Payers can be health plans. It can be federal, state, local government, can be employer groups, can be, and if you're a private pay, you're trying to minimize the cost of your expenditures. So you've got, on the other side of that coin, you've got the payer, and they're trying to minimize the cost of healthcare goods and services, the act of consuming those costs of healthcare goods and services. And if you're an organization like a health plan, you're also trying to maximize profits. If you look at a lot of the health plans, if you follow them on the stock exchanges, you've got United, you've got Centene, you've got Cigna, you've got Aetna. They're all out there. They've got earnings per share. They have, investor meetings. They've got individuals on their stocks. So they're trying to drive profits. So same financial coin, the struggle in the environment, the environment today is between the provider and the payer. They're both struggling for that financial coin. And right now, I would say that the payer is probably winning to a certain extent. And what I want you to think about as we not only go through, the rest of this discussion today, but as we go through the rest of the chapters in the text, I want you to think about building this toolbox, because when you graduate, and if you want to get into the healthcare environment, and you want to, let's say you don't have the grades to get into medical school, you may want to go into the healthcare environment as an analyst, as somebody on the finance side of the house. You may want to work in medical management, network management. You may want to work in IT, and you want to understand the economic and financial underpinnings of no matter which side of this financial coin you decide to work on. And to those that aren't in the healthcare marketplace right now, you have individuals that are constantly flipping from one side of that coin to the next. You see it a lot in health plans where you'll have somebody in network management on the health plan side that's been negotiating contracts with providers. Next thing you know, they've left the health plan, gone to the provider side of the house, and now they're negotiating health plan. Now they're negotiating rates for they're negotiating rates for the provider side of the house. So they're taking the information that they had on the health plan side, they flip to the provider side of the market, and vice versa. You have individuals on the provider side, and the next thing you know, they flip to the health plan side. So it's not out of the ordinary to see individuals flipping back and forth on either side of this financial coin. And so as we think about it, kind of going forward, and there's one other concept before I kind of get on down the road here, is that you've got provider groups are typically based, providers and payers, health plans especially, you're either for-profit or not-for-profit. And I'd always worked for, for-profit health plans until I went to work for Blue Cross Blue Shield. And it's because it's a not-for-profit. And not-for-profit doesn't mean that the healthcare doesn't want to make money. It's just a tax designation for the health plan. And years ago, as you go back and if you read that article we talked about earlier, by Kenneth Arrow, it was a designation that kind of altered the perception of the consuming population, because they thought if they went to a not-for-profit provider, that profit wouldn't be a motivator in the treatment plan they received. But if you go to work for a not-for-profit health plan, things get a little different when it comes to salary and bonus and some things like that. But at the end of the day, they still want to make money because they need to make money to stay in business. So just be aware that, go to work for a for-profit health plan or for-profit provider, going to be a little more pressure on you to hit your financial goals, to meet all your annual goals. You'll have, maybe stock options, you may have, bonus potential. You look at a not-for-profit, you're probably not going to have any stock options. You might have you're going to have a lower bonus potential, but there may be a little more stability there. So that's kind of my spiel on the for-profit, not-for-profit. But if you start thinking about if you're going to work, again, either for a provider or a health plan, you want to think about understanding the market as a whole. So if you look at, and we'll just talk about the providers for a minute, if you think about cost on the providers, it's the actual cost to the provider are their actual expenditures, fixed and variable costs. So that's going to drive the cost of the provider. Then you have bill charges or charge amounts. They are driven by the provider's charge master, and it's a result, it's the amount that's billed to the payer. And while a lot of people that get into healthcare, at least initially, don't understand that the actual cost of the provider does not always equal the billed amount that goes to the payer. Those billed amounts are inflated a certain percentage amount, and it's going to vary from one provider to the next, and it's embedded in that thing that they call the charge master. When you talk about allowables in the healthcare marketplace, you're talking about the dollar values that are determined by those individuals, either on the payer side or the provider side, that are negotiating those contractual or payment arrangements during the negotiation process. And, some providers and some health plans negotiate contracts once a year, every year that go into effect January the 1st. Some negotiate 2- and 3-year contracts with escalator clauses built into them. Let's say that a 99213 is the code that they bill for just a medium office visit. So, here's your office visit. You go into them, you've got maybe a cold or something. The provider sees you for like 15 minutes and, writes you maybe a script or something. He goes on to the next one. That's, typically a medium office, kind of a medium level office visit. And let's say that the providers negotiated $60 for that office visit with the health plan. If it's a 2- or 3-year contract, they may have escalator clauses in there that it may be $60 the first year. In year 2, it's increased by, the consumer price index, or, maybe they negotiate some kind of an inflation escalator into that contract. And then again, it'll be built into level to year 3. And those contracts, 2- and 3-year contracts, typically are referred to, at least by some individuals, as evergreen contracts, because they keep rolling over as long as those escalator clauses are in there, as long as one side or the other, either the payer or the provider, doesn't decide to terminate the contracts and an agreement's reached and there's buyouts and that sort of thing. So that's what the allowables are. And then the payables, when you're talking about payables, the allowables is what's negotiated. The payables are the dollars that the health plan actually sends, on the invoice to the provider. And it's not a paper check anymore. It's usually an, automatic, withdrawal from the plan goes automatically into the bank. So like an ACH type of payment. And that's basically your allowable amount. So you're talking about your contracted amount that's been negotiated. And it's usually minus whatever the member liability is. My health plan, if I go to see my primary care doc, I have a $10 copay. So if the negotiated rate's $60 and I've got a $10 copay and I pay that up front, then the health plan is going to pay the provider $50. And that's kind of the way the finances work. And then we, want to touch base just quickly for a few minutes and talk about, what is health economics. Most people don't really know what an economist does. They may have had a micro class, they may have had a macro class in an undergraduate degree. If they learned anything, they've may have already forgotten it. So when you just like when I tell somebody I'm an economist, I get a lot of blank looks, just like kind of these deer in the headlight looks. If I told them I was a doctor, a lawyer, a policeman, a fireman, a real estate agent, they'd have a pretty good idea what I did. But when I tell them I'm an economist, it's really difficult. They have trouble even asking questions, trying to stimulate a conversation. And when you're talking about health economics, you're talking about analytics, you're talking about predictability, you're talking about forecasting. You're dealing with terms, efficiency and effectiveness, value. You're looking at social choice, socioeconomic limitations, talking about behaviors of production, consumption of health and healthcare. So a lot of those terms that you hopefully would have remembered from your micro classes, they're starting to be embedded into what's really occurring if you move into health economics. If you want to be in healthcare and want to be part of the healthcare marketplace, and you either can't get into medical school or nursing school or don't want to go those routes, being a health economist it's actually a very lucrative opportunity. All you have to do is go out and look at Indeed, LinkedIn, all of these job boards. There are a lot of individuals making significant dollars working as analysts, helping health plans, helping providers with their forecasting, building financial models, helping them predict, helping them estimate where they're going, what it's going to look like. So it's definitely, from my perspective, it's been a great, I guess, avenue for me to generate income and to provide for my family. So and also in health economics, you're talking about improving outcomes. You're looking at lifestyle patterns, interaction between consumers, healthcare providers, different clinical settings. When somebody presents at the emergency room in the hospital, are they going to be admitted to an inpatient? Are they going to be put on a gurney and moved out in the hall in what they call an observation unit? They just want to watch you to make sure you're not going to get worse. Maybe they roll you out to the outpatient side. Rather than going through the emergency room, they might, the nurse triage you and send you to urgent care. They might just, triage you, send you to urgent care, give you some scripts, and out the door you go. If you do need surgical procedures you're talking about in your doctor's office, he may say, well, this is an elective surgery. We're going to have it done in an inpatient side. You may get something back from your health plan and say, no, not so fast. We have better outcomes. It's more cost effective. We're going to get you home sooner if you do it as an outpatient surgery. So all of that is as a healthcare economist, you're knee deep in all of these decision-making processes. And healthcare economists explore the function of the healthcare system and health affecting behaviors. So unfortunately, healthcare is not customer centric. There is a cost to information. Price and quality are really hidden values. You go in to see most people will go in to see to their provider with an episode of care. Provider will diagnose them. They'll create a treatment plan, may give you some scripts, may send you to see a specialist. If your back's hurting, they may, have you go to get an X-ray, an MRI. They may send you to physical therapy. There's all of these kind of collateral opportunities for providers to keep you in the medical care system and you may feel like you're like a ping pong ball, or bouncing back and forth within the healthcare system. But that's the issue with healthcare, because price and quality are somewhat hidden. You don't know the cost of your office visit. Oh, you're paying $10 out of pocket, but you don't know the true cost to the health plan of that office visit. And there's always uncertainty, not only with the occurrence of healthcare or the occurrence of an episode of care, but also the efficacy of the treatment regime that is afforded you by your physician. And then there's always, as an economist, whether you're working on the provider side or you're working on the health plan side or the payer side, there's always this struggle for control of this financial coin. And that's done via costs, charges, allowables, payables, which we talked about earlier. They talk about, there's government intervention. Government's always, government always thinks they know better than anybody else how you should function as a consumer. So, it's almost like the government's the parent, you as a consumer's a redheaded stepchild or something, and they're always trying to dictate to individuals how they should function and how they should consume. So within the healthcare marketplace, there is a lot of government intervention. You've got TRICARE Champions, you've got Medicaid, you've got Medicare, you've got state, federal, local intervention. Your government's always in the middle of it. Then there's the risk and, financial risk and uncertainty of the providing healthcare services. There's, as we've talked about, there's the issue with asymmetric information. Providers, for the most part, have access to more complete information. May not be better information, but it's more complete information than the consumer or the patient does. There's barriers to entry. So you've got the AMA, you've got federal government sitting out there trying to control the number of physicians getting into medical school, trying to control the licensing and the accreditation as they come out of medical school, trying to, at least in theory, improve quality of care as physicians and healthcare providers are coming out of their medical school programs. And then there's all these externalities. And when you talk about an externality, you're talking about something that happens that you may not have control over. So think about COVID. During COVID, you had individuals that went in and refused to be vaccinated. For one reason or another, they just refused to be vaccinated. They may not have washed their hands as regularly as they thought they should. There were a lot of things that could have reduced the spread of COVID, but it didn't happen. And so individuals that, went in, tried to take care of themselves, had the vaccination, tried to do everything right, there still were some side effects to them because of others that had not taken the same route. So there's all these externalities out there focused, impacting not only the health of the population, the medical care that's provided, and then you kind of roll the health of the population, Medicare provided, and that kind of rolls under the umbrella of this big umbrella of healthcare. And then you've also got what they call third-party agents. You've got the health plan, sitting there. So you've got Mr. or Ms. Consumer, you've got the healthcare provider, you got, trying to provide you healthcare goods and services. You got the, government agencies sitting up here, trying to dictate what everybody does. And then you've got the health plans down here trying to ensure that you get the quality of care that you need. But at the same time, they're trying to control costs because they're trying to make money. And then want to talk just a few minutes about production and consumption indicators. So efficiency measures the resource allocation driving value. everybody wants value when they spend their money. And healthcare is no different. You want a value for that. In my case, the $10 I pay. I want to make sure, and that's my direct cost is the $10. Doesn't have anything to do with the indirect cost of the transportation cost for me to get there. And at least here in Atlanta, you go to see a doctor and there's, you're having to pay to park. And they've got a really slick gig going in Atlanta on the parking issue. If you go in and you're there less than 30 minutes, it's free. Anything over 30 minutes up to 3 hours, I think, is $7. When's the last time anybody? The last time I never go in to see my provider and get out of there in 30 minutes. It just doesn't happen. They want you there 15 minutes early to fill out paperwork and make sure you're going to show. And then you get there on time, you get there early, on time, and the physician's late. And so I just allocate at least an hour every time I go to see my physician, from the time I park to the time I come back and get in my car and leave. And so there are all of these indirect costs, plus the amount of time, the opportunity cost I'm lost, because I could have been doing something else other than driving to the doctor's office, being in there yakking with that character for an hour, and then, driving back home. So it's just not a pleasant situation. And it's just the environment that we deal in with healthcare. And as a healthcare economist, you're going to be right in the middle of that. Value is, it's measured by quality and cost, and effectiveness is the ability of an intervention to positively impact healthcare outcomes. You go in to see your physician, your healthcare provider, you want a positive outcome. If you've got a cold, you want to make sure that within a couple of days you're feeling better. If you sprained your ankle, you want that provider to do something so that when you hobble out of there, you're going to be better in a couple of days. And so consumers look at value for their money is, what are the quality and what's the cost? And again, for consumers, the cost, $10, transportation, lost time. There are social choices and socioeconomic factors that include access, cost, you're banging on disposable income, education, lifestyle, principal elements of medical care. And a lot of this goes back to kind of if you think about it, and we'll get into it in the text, but you're talking about just kind of like a triple option. There's health, there's medical care, and there's healthcare just kind of encapsulates everything. So when you're talking about lifestyle and you're talking about education, you're talking about kind of this health piece of it. What can you do yourself, through your lifestyle and your education and your understanding to optimize your stock of health, let's call it. And then you've got medical care, and the medical care, whether you go to the doctor or not, may have something to do with your disposable income, may have something to, may be impacted by your transportation, may be impacted by access. I mean, I can't remember the last time I picked up the phone, called the doctor in the morning and said, I need to come see you because I'm just, I sprained my knee and I need to come see you. Trying to get in to see at least my physician on the same day, it's just not going to happen. So, now we're talking about access. And, you're talking about, that's the medical care part. And then you've got the healthcare that's kind of combining health, medical care, and everything the third party does over here. So they're trying to control the third party, government, whatever you want to lump in that third party. And if you go back to your stock of health, and those are behaviors. They include, not limited to how much sleep you get, what's your diet like? Do you go to the gym? Do you get any physical activities? Do you smoke? Do you consume alcohol? If you do, how much do you consume? Are you, do you smoke marijuana, or you're on some other kind of drug. So that's where we're getting into the health aspect and what you can do to help improve the health aspect. And as an health economist, you again are going to be knee deep in that, because you are going to have a chief medical officer. Let's say you work, and it doesn't matter whether you work for the provider or you work for a health plan. If you're on a provider side, especially in a multi-specialty group, or you work for a hospital, you are constantly going to have the CFO, you're going to have the CEO, you're going to have the chief medical officer. You may have the on-site actuary constantly asking you, well, what about this? What happens if? What information can you provide me to ensure that we are efficient and as cost effective as we can? Because if we're efficient and we're cost effective, that's going to drive profits. Last thing I want to quickly touch on, the distinguishing factors for health economics. Just in general, you've always got to worry about government intervention. And that's state level, federal level, local level. You've always got that going on. And in the state of New York, when I worked for Blue Cross Blue Shield, you always had the Department of Financial Services, DFS. You had the Department of Health, DOH. They were always looking over your shoulder at the health plan, constantly having to talk to them on the phone to justify why you did something a certain way. So, that was at the state level. City of Buffalo, you always had, individuals looking over your shoulder, trying to figure out what's going on. And, you talk about in health economics, we talk about, information and risk, and risk implies partial information or probabilities, and uncertainty, randomness, and it's just intrinsic to health. It implies the unknown. Of all the market economies that you could go into as an economist, the data, the quality of the data that we have in healthcare, it lacks a lot to be desired. It's driven by how the provider bills the claim, how the health plan pays the claim, whether the covered member provides the provider and or the health plan accurate information. Let's say somebody's hurt at work, and they go into the provider, and they've got they've banged their shoulder at work or hurt their wrist or something, and the provider says, did you get hurt at work? And the member says, oh, I didn't get hurt at work. And so, because if they're hurt at work, it might have gone into workers' comp and be paid out of a different pot of money. And so it's this asymmetric information. It's on the provider side, but it's also on the member side too, and it's on the health plan side. There's not a lot of cooperation, and healthcare just in general it's somewhat like a dysfunctional family. When you're talking about getting information and disseminating information and sharing information and transparency, when you're talking about the provider, you're talking about the health plan, you're talking about the government, the government looking at you, you're talking about the member that's not sharing information. So it's a messy situation. But at the end of the day, as a health economist or a healthcare economist, you're almost like a detective. You're in there trying to figure out, based on the information you have, exactly what's going on with respect to cost, to quality. You're looking at, average cost per episode of care. It's just a lot of interesting information that you're trying to distill and feed it into some type of an economic template that helps medical management, that helps network management, that helps the CFO try to develop a strategic plan, whether you're on the provider side or whether you're on the payer side. And then the last thing, I think that's going to pretty much wind it up as far as our kind of our precursor as we get into health economics. One thing that I always tell students, and once you get out into the workforce, if you read detective novels, if you watch, detective shows on TV, if you look at murder mysteries, and embedded in a lot of these fictional books, and also these TV shows, you have you continually hear people say, all you got to do is follow the money. To figure out what's going on, follow the money. And if you don't remember anything else that I try to provide you during this, class, and this, we've got 15 weeks together, I guess, or 16 weeks. If you don't remember anything else that I've said, always remember, whether you're on the provider side or whether you're on the payer side, if you don't understand why something is occurring with respect to the provision of health care, with respect to how that claim is being paid, always follow the money, because providers, health plans, they're all trying to optimize something. Remember, go back to your micro classes and think about opportunity cost, self-interest and optimization, making decisions at the margin. And that's why if you follow the money, you will be successful if you decide to go into health economics, whether you end up on the provider side or the payer side. Just always remember, follow the money. And with that, we're going to end this. And the next time you see me, we're going to be jumping into chapter 1 of the textbook. Thanks for joining, and talk to everybody later.